Welcome to the NWAETC Project Echo. I'm Kent Unruh. I'd like to turn it over to Dr. David Spock to introduce our guest.
Well, welcome everyone this afternoon. We're very fortunate to have Dr. Julie Dombrowski, who is going to talk to us about linkage to care. Julie is an assistant professor here at the University of Washington, and she's the deputy director at public health at Seattle King County HIV/STD program. And Julie has really led our region in innovative work in the area of linkage and retention to care, and she's really had some outstanding results in the greater King County area. So we're going to hear from her what's new in linkage to care.
Great. Thank you very much, David. And hello, everyone. I'm excited to have the opportunity to talk to you today and to see how Project Echo works. I'm going to start off the talk with a case study of the latest patient I saw who had a non-ideal linkage to care. He was a 42-year-old man from sub-Saharan Africa. He immigrated 2 years ago, and he was hospitalized in a private hospital with community-acquired pneumonia. He was appropriately diagnosed with HIV, never had a previous HIV test, and he had a CD4 count of 160 at that time and a viral load of over 1 million. He was discharged from the hospital with a prescription in hand for Bactrim and an HIV clinic appointment. However, when he went to the pharmacy, he was asked for cash to pay for the Bactrim. He didn't have anything to pay for it, so he didn't pick up the medication. He similarly inferred from that he would not be able to afford HIV care and no-showed for his HIV clinic appointment. Public Health Partner Services in King County then got a hold of him about 2.5 months later when we got the case report, and it looked like he had not linked to care. And at that time, brought him into our one-on-one program in the STD clinic and let him know about care and medication assistance programs, the timeline for HIV care and why it was so imperative for him to link to care, and some basic education about contemporary ART. He completed an appointment with a case manager and HIV medical provider in Madison Clinic just 3 days later. And since then, he has actually done very well. He's being arranged to start on ART expeditiously, and he's followed up with his other appointments as scheduled, but had what I would say is a non-ideal linkage. So as I think this group knows very well, linkage to care is really crucial for successful HIV treatment. It is the doorway to antiretroviral therapy. And delayed linkage impacts medical outcomes and probably impacts HIV transmission. Delayed linkage leads to a longer time to suppression, increased risk of hospitalization and death, and increased transmission risk. And importantly, I think also to note that the linkage experience, the way the patient experiences it, can really lay the groundwork for their future retention in care. So let's first define what we mean when we say linkage to care. This term is used in many different ways, but strictly, linkage typically refers to initiation of HIV care, completion of that first medical appointment after diagnosis. And after that, connection with care is typically referred to as retention in care. The standard metric for this, unlike retention, is well agreed upon by HRSA, their metric, the CDC, the Institute of Medicine, and the National Strategy have all used the metric of linking to care within 90 days of HIV diagnosis. The national strategy set a goal for 85% linkage within 3 months. We are nearing that in the US, but still a little ways off. This is the latest nationwide estimates from the CDC. The first few bars in this cascade do use nationwide surveillance data to estimate linkage to care. So approximately 80% of people who are diagnosed with HIV link to care within 3 months. That, again, is higher than initially estimated with the national strategy. But when you account for the fact that approximately 18 to 19% of people with HIV are non-diagnosed, that means only 66% of all people living with HIV have linked to initial care. Barriers to linkage are many, and I think we all have experience with patients who have experienced some of these. One way in which these are often grouped was put forth by the Institute of Medicine, which is thinking about barriers in terms of financial, structural, or administrative, and personal. So financial barriers, I think, is really what our case study patient encountered, and truthfully, it was only a perceived financial barrier. In Washington state, all persons with HIV can have care and medications paid for, regardless of insurance status. An uninsured patient like him would certainly be eligible, but he didn't know that. Even for patients with insurance, competing subsistence needs like food and housing can certainly take priority over linking to care, especially if they're feeling well. Structural and administrative barriers, in my experience, are, in addition to financial, probably the most common barriers. People often just don't know how to get through the system. They have long appointment wait times, or they somehow can't get an appointment. Personal barriers certainly come up and do happen, although I don't think that they are as common as the others, and I think many of these can be overcome with changes in our systems. Stigma of HIV, sexual identity, and drug use certainly come into play, and some patients have difficulty accepting their diagnosis or certainly are struggling with comorbid mental illness and substance abuse. Risk factors for failure to link. The data I'm showing you here come from a number of studies, some of which are population-based. And on the left, I've put forward the factors that really are very consistent across studies. So African Americans definitely have, in almost every study, delayed linkage or reduced rates of linkage. Residents in a high poverty area, lack of insurance or public insurance compared to private insurance, both confer a higher risk of failed linkage. Lack of primary care prior to HIV diagnosis, I think, speaks for itself and again points to people getting caught in the system. Substance use, certainly crack is a very common risk factor, and history of injection drug use, something we can tell on case reports, also leads to delayed linkage. Other things have been inconsistent. Most studies have found that female sex is a risk factor for delayed linkage to care, but in South Carolina, for instance, it looks like, for whatever reason, male gender appears to be a risk factor, so that has not been consistent. Age, similarly, youth is typically a risk factor, but there are some studies, again, in the South, for whatever reason, that seem to suggest older patients are actually at higher risk for delayed linkage. Earlier stage of HIV disease, either denoted by a higher CD4 count or lack of AIDS diagnosis, is a risk factor, as is birthplace outside of the US and probably tied to that Latino ethnicity. Depression is another mixed one. Depression for both linkage and retention in care in some studies is a risk factor, and in some studies actually seems to be associated with increased use of care, probably by a confounder. What about the reason for HIV testing? It certainly makes sense that someone who's tested through routine care may have a different experience than someone who goes into, for instance, an STD clinic seeking a test. These are really hard to compare, and we don't have great data. I would say there are no data that I have found comparing emergency room diagnoses to non-emergency room diagnoses. In South Carolina, New York, and Philadelphia, they each classified sites of diagnoses differently, and again, a state facility in South Carolina or a county health department in South Carolina is probably quite different than a public clinic in Philadelphia. So I'm not sure how to compare those, but certainly it seems that in general, people diagnosed in the hospital, people in sites with co-located care, and again, I suspect that has to do with somebody directly linking them into the clinic, seem to do better with linkage. And in one nationwide 18-state sample, people who sought anonymous testing did have lower rates of linkage to care. So let's talk about strategies to improve linkage with a specific focus on what clinicians and the clinics can do. There actually are guidelines for linkage and retention in care that were published by the International Association of Physicians in AIDS Care, or IAPAC, in Annals of Internal Medicine last year. The recommendations that they had related to linkage were systematic monitoring, strengths-based case management, considering patient navigators, and considering intensive outreach, and we'll walk through each of those. It's important to note, though, that linkage to care is, by its very nature, something that the clinic has to share responsibility with other entities. Most HIV clinics are not doing the majority of HIV diagnoses. People are tested in a site where there are typically primarily HIV negative patients with them. And public health really needs to be involved for it to be a truly population-based activity. So ideally, the responsibilities are shared between each of these three entities, and that really has to be established somewhat on the local level. For instance, here in Seattle, in King County, we do have public health partner services for all persons with newly diagnosed HIV. We attempt to reach everyone, and we don't close cases until we can ensure they link to care. And part of that comes through a very strong relationship with the Madison Clinic that allows for things like the 3-day appointment in our case study. So this needs to be worked out certainly on the local level, and I suspect many of you have strong relationships with your public health department. One thing that I think clinics and providers can really do is monitor and work to improve no-show rates for new patients. So that is something the clinic has a way to track and intervene. No-shows for when new patients have no-shows, that really should trigger an intervention. There's not a lot of research on this, and I think the intensity has to depend on clinic resources. But in general, even just notifying patients that they've missed an appointment and need to reschedule it, all the way to more intensive outreach, should be considered. Case management, I think we all know, is really key for linkage and retention in care. There is not a lot of strong evidence for this in terms of randomization. Most of the studies on case management are observational in nature, but case managers help clients navigate or patients navigate complex medical care systems and can also connect them with counseling and psychosocial support, as well as provide some basic HIV education that's really needed for people with a new diagnosis. However, the recommendation in the guidelines comes from the one randomized study on a type of case management that is called strengths-based case management. This was a study performed by the CDC. This intervention is called ARTIS, or the Antiretroviral Treatment Access Study. And there was a randomized controlled study in 11 U.S. cities that essentially compared standard of care to an approach where a trained social worker would meet individually with a newly diagnosed person and really focus on their strengths and assets and work with the client to figure out how to use those to encourage their linkage to care. My personal thought is that this didn't include enough actual functional assistance linking to care, and that I think that could have helped with what was still a low linkage. They had 78% linkage within 6 months in this study compared to 60% in the controls. This is, however, being implemented and disseminated throughout the U.S. with CDC doing several trainings. And one of the limitations is that it is relatively resource intense since you need trained persons who can conduct up to 5 sessions. Peer navigation is a model adapted from the oncology setting. This involves using trained peers to help navigate the healthcare system. This is being deployed in a lot of areas, both by public health systems, community-based organizations, and some HIV clinics. There are no controlled studies for linkage to care, and in related interventions, peer effects generally for patients with HIV increase knowledge, but don't necessarily show in most studies an effect on biomarkers. Here I'm speaking about viral load. However, there was a SPINS initiative that suggested effectiveness. HIV Care Orientation is another thing that I think clinics really can do to help improve linkage experiences. This involves essentially letting patients know what the process is like in the clinic, but also orienting them to the discourse of HIV as a chronic disease and orienting them to the timeline of HIV care. We all know as providers, there's a general pattern, depending on how sick you are and what your CD4 count is when you enter care, of how long it will take to get on ART, the frequency of visits around that time, and what will happen after someone is stable on ART. But orienting patients to this can really help. Interestingly, this is the standard in transitioning adults into adult care clinics. There's a lot of work with adolescents around orienting them to the care process in clinics, but I don't think we do this in general, certainly not nationwide, with new adult patients. This also came up prominently in a recent paper by Kat Christopoulos at UCSF, that this was something patients mentioned a lot, that they appreciated and needed. UAB, the 1917 clinic, that's their HIV clinic, has what they call Project Connect. Every patient who calls to schedule a new patient appointment is brought in for Project Connect within 5 days. They complete a questionnaire. It's very similar to a case management intake. They get their baseline testing. They see a social worker, get started on prophylactic medications, and get mental health and substance abuse referrals started before the patient ever even sees a medical provider. They have all of this information easily accessible on their website for new patients, and they say that this has dropped their clinic no-show rate for new patients from 31 to 16%. It appears to be very cost-effective by other standards that have looked at this, with a cost of about $1,600 per additional patient linked to care. Again, I think this gets back to locally how you organize these sorts of things with your various partners. Intensive outreach is really, interventions are not well defined, and I would say are changing rapidly and highly variable across the U.S. Many health departments are starting to use surveillance data to really identify people who've not linked to care, do individual outreach, and assist them with linkage. Which leads me to talk briefly about public health partner services in my next to last slide. Partner services, many people think of as being primarily about helping newly diagnosed patients notify their partners and arrange for them to be tested. But a key goal of partner services is also assuring that someone links to care. This really varies pretty tremendously geographically. In the US, less than half of people diagnosed with HIV receive partner services. In King County, as I mentioned earlier, we do attempt to provide this to all new cases diagnosed with HIV. And I did the whammy states instead of the appropriate states for ECHO. I can change this here. I don't have Oregon here and can change that. But this is, from what I understand, talking with health department leaders in each of the states. In Alaska and Washington, there are, both of those states, the standard of contacting all new cases and assisting with linkage to care. In Idaho and Wyoming, patients are attempted to be contacted and typically connected with a case manager to ensure linkage to care. And in Montana, this is really a part of the funding mandate and contract for testers that they ensure linkage. It's really separated from partner services in Montana. So in summary, linkage to care is a shared responsibility of diagnosing sites, HIV clinic, and public health. Success is considered to be your first visit within 3 months. About 20% of people diagnosed with HIV nationwide still do not meet that goal. And case management, active assistance, and follow-up to ensure linkage are really crucial. For providers and clinics, intervention for no-show new patients and orienting patients to care, I think, are useful interventions and programs to consider. So with that, I'll finish. Thank you.